Thank you very much for the invitation. It's always an honor to be here. Condensing the 50 years in 15 minutes is very difficult. I will try my best, however. Well, if you look at our background, the story starts in 1977 when Hochbach identified the first patients that were treated through PEEP, achieving some results. But, however, I would say that, just to make the story short, that the real ARDS should be the diffuse alveolar damage. You all know that just for making the diagnosis histologically is almost impossible or very, very difficult in our patient at bedside. The story indeed starts even earlier. During the pandemic of polio in Denmark, and where Björn, for the first time, applied through the tracheostomy a form of mechanical ventilation that was the manual ventilation, where the resident ventilation. But at that time, this caused a dramatic increase in survival of these patients immediately after the tracheostomy and the manual ventilatory assistance. Then came the Hochbach. He indeed identified some patients with various etiology, a large part viral pneumonia, and in them he applied a form of PEEP, one of the first rudimental application of PEEP. And what he got was a dramatic improvement of PaO2 after he started the ventilation. And this is a very important achievement. Then we jump to changing the concept, we jump to the modern concept of the low tidal volume. The famous study of the NIH trial showed that a decrease in the tidal volume may get a benefit in terms of mortality. But indeed, looking at the history, there was always a balance between the concept of oxygenation and the concept of lung protection. And the oxygenation is indeed one of the major points to look at that characterize also our way to define the ARDS over the years. This is the American Consensus Conference in 2004, in 1994, when the different levels of PaO2, VO2 could allow the identification of different severity. This in part has been maintained in the new definition. However, as soon as you look at the application and you see the advantages of the lower tidal volume, a very interesting aspect should be taken into consideration, that those patients who had a better PaO2, VO2 were the patient allocated into the control. So it means that despite there was an improvement into the mortality rate, the oxygenation maybe was not as important as we may be. And indeed, over the years, gradually, the concept of oxygenation moved through lung protection, which is a more actual way to look at the story. And this was in large part related to the studies of Lasky and many other colleagues. The first one that identified the story was Didier Dreyfus here in France, and where the idea of the volotrauma and the overdistension of the lung was associated to the idea of a biotrauma. And I'm sure that later on, Laurent Papazian will speak about this aspect. Then this concept led also to a different way to look at things. And Marcelo Amato has proposed a variation of the visual angle, starting from the scaling of the tidal volume based on the body weight, or the ideal body weight, to the compliance. In other terms, the relationship between the tidal volume and the compliance, which is the delta pressure, driving pressure. And so changing this mentality, more and more we were addressing the idea that a small tidal volume could have been one of the best solutions in this case. Well, this concept was pushed the most from the group of Lasky, and they proposed an ultra-protective strategy, very low tidal volumes, 3-4 ml, associated with extracorporeal CO2 removal, and gaining quite good results for those patients who had a PF below 150, with an increased probability to be weaned from the mechanical ventilator. Very recently, the study that was promoted by the European Society of Intensive Medicine trial group, the Supernova trial, whose PI are Marco Ranieri and Alan Combe, achieved very interesting results. By using very low total volume, 4 ml per kilogram body weight, and the extracorporeal CO2 removal, gain a significant decrease of the driving pressure, and ultimately, even though this was just a feasibility study, not a study to show any difference in mortality, the survival rate at 28 days was 73%, so something that should be considered. However, as soon as another important aspect concerns the fact that as soon as we keep the spontaneous breathing, the inspiratory swing that can be obtained by patients spontaneously breathing may be very high, and then consequently generating an high and potentially harmful transmural pressure. Well, the possibility to solve this problem, at least at the very beginning of the syndrome, is just to apply the Laurent-Papazian suggestion in the study, where the use of the neuromuscular blocking agents during the early phases of the ARDS may make a difference. And indeed, in this study, it showed that the application of this principle could just reduce the mortality rate at 90 days. However, if this is true, it is also true that when we use and we apply the low tidal volume, and this has been shown by Laurent Brochard group, is associated to also alveolar derecruitment, in a way or another also an higher risk of VLEEP. Well, in order to keep in mind this concept, the aim is finding out a balancing between recruitment and over-distension. Well, if we look at the higher versus low pressures and the respiratory pressures for the treatment of patients, the results can be frustrating because in a way or another there was no real substantial benefit in applying this idea. Then probably I wouldn't say a solution, but an interesting suggestion is the one given by Daniel Tarmo, who says, let's take into account the compliance of the respiratory system and maybe obtain a partitioning between the lung compliance and the chest wall compliance through the measurements or through a nasoesophageal catheter of the pleural pressure. This may be very helpful for setting up our ventilator and giving a real protective ventilation to our patient. He developed a sort of table similar to the NIH-1, but taking into account the esophageal pressure. And he showed that by keeping into account the esophageal pressure, he could maintain safely higher level of the plateau pressure, higher level of PEEP, and achieving ultimately, even though the number of patients is always limited, also a benefit in terms of 28 days mortality. The other point is pointed out by Alain Mercat, just following the idea that the recruitment or maximizing the recruitment may make a major difference. And indeed, in the two groups of patients, including in this study, he achieved a quite better PaO2, VO2 as soon as in shown here. By applying this strategy. However, there was no difference in the mortality rate. So probably the explanation that is behind this concept is again the idea that the driving pressures counts the most. And if the PEEP that you apply, higher or lower, may keep the driving pressure more or less constant over time, means that as the analysis showed, that the best benefit of the higher PEEP exists only when there is a reduction of the strain and consequently keeping at the same level the delta pressure and the recruitability. However, we know that the recruitability of the lung through the study from Luciano Gattinoni may be very different and very sparse and in very different regions of the lung. And the percentage of potentially recruitable lung being extremely variable renders a very different response to the PEEP. Another idea could be just proning the patients, because the prone of the patients may induce an improvement of the oxygenation, increase the end expiratory lung volume, better ventilation perfusion matching, and a more efficient drainage of the secretion. And Claude Guérin, another of the our chairmen, just showed that by proning these patients, provided that the fact that it must be achieved an adequate duration of the proning, may make a difference, an important difference in terms of mortality. However, there are also other tools that over the years has been used to treat the ARDS. One of those is certainly the ECMO. The ECMO is the veno-venous ECMO that is in general used for the treatment of the acute ARDS. And after the studies from the Luciano Gattinoni groups and Theodor Kolobov groups during the 80s and 70s, there was a revamp of the technique during the epidemic of the H1N1, and where a number of patients were treated, but one thing that should be always kept in consideration, that this is not a trivial technique and often does have also important complications such as the hemorrhage and intracranial hemorrhage, something that always should be taken in mind. Finally, I would make an ultimate consideration concerning our ability, despite all the tools that we have available for treating our patients, how effective may be and how good can be our capability to identify patients with ARDS. And this is a discouraging result, because the lung-safe studies show that at least for the milder form of ARDS, we may miss the diagnosis in the early phases by something like 50%, which is very discouraging. And this corresponded also to a mortality rate that is quite high regardless the severity of the category. And the mortality rate in this study has been shown to be proportional to the level of the driving pressure and plateau pressure that has been applied. So what could be for the next 10 years the ideas? Driving pressure as a therapeutical tool? Maybe yes. In this sense, are we living already a golden age? Maybe not, but this could be an option. The feasibility of CO2 removal as a standard of care to lower tidal volume is still under judgment, but I think that is very promising. And for sure, and I think that Laurent Brochard will speak extensively on that, the individualization of the PEEP setting may be the other answer. Thank you very much.